It's my pleasure to introduce Paula Richley Geigle. Paula is a physical therapist and also a clinical researcher. She has served on the aquatic physical therapy section in various positions. She was president, she was secretary, she's been journal editor, bylaws chair. She also was the first recipient of the aquatic physical therapy section clinical research grant, which her study was on the role of aquatic exercise in breast cancer-related lymphedema management. Paula is currently collaborating with a group of international aquatic practitioners to prepare an aquatic and swimming pool World Health Organization white paper. Paula has received her undergraduate degree from the Pennsylvania State University as a science major, physical therapy training at Hahnemann University, a master's degree in biomechanics and doctorate degree in education from the University of Delaware, and an NIH-funded postdoctorate degree in complementary and alternative medicine-funded postdoctoral experience at the University of Pennsylvania Medical School. It's my pleasure to introduce Paula.
Good morning. So I'm fairly informal as a speaker, and I tend to wander, so they put the traveling mic on me, which is a good thing. If you have a question, just let me know. We don't have to wait to the end. What I'm presenting today is our protocol of the study. We have not disclosed or opened the data yet. So what I'm going to show you is what's possible from a clinician point of view. And when I was listening to Byron speak this morning, what do I want to share with you? What perspective am I bringing that's a little bit different? And the perspective that I think I'm bringing is most of us as practitioners realize that movement is good. So as a young therapist, we used to call it bag and drag. We'd get people up in ICU. We'd move them while we actually were still ventilating in some cases. Of course, they have more sophisticated methods, but it's still the same thing. Get them up, get them going. And we knew that somehow we were breaking this cycle of degeneration. What I didn't understand at that point in my career, because I didn't have some of the education, I didn't have some of the knowledge, but there was a gut feel that movement was helping prevent a downward spiral. What I would like you to think about is how can aquatics help with this movement piece? What this study is looking at, and what I've come to understand with that boatload of education and clinical experience, is that the metabolic underlying mechanistic piece is something we need to investigate more thoroughly. What are we impacting by our movement? So whether it's with body weight support, treadmill, or aquatics, which this study is comparing, what are we actually doing for the person? Cytokines right now are a very sexy, hot topic. Glucose and insulin balance is a very hot, sexy topic. They're more than hot and sexy. They will get research funding dollars, but in my heart of hearts, I think somehow these mechanistic underlying premises are all tied to why the movement is good. The movement starts helping people heal. It stops that whole degenerative process. It may not alter chronic disability like individuals with these motor incomplete spinal cord, but what we might be able to do by using this movement is to basically prevent some of the secondary conditions. So that's my mindset when I come to you today. I don't have all the answers. I have, again, a boatload of questions. I do have a lot of ideas. So I'm going to share these ideas. The study that we put together is funded by the Department of Defense. I'm going to walk you through the protocol, and then what I'm going to do is ask you for your help to think about what next, and any ideas you can come up with from your practical clinical backgrounds to help us see if we can improve the study it's currently. We're in year 2 of year three study, and I'm going to go ahead and click through my slides. Again, any questions as we go along, just stop. Remind me to repeat the question so everyone can hear it, and then we'll go from there. So basically, what we're looking at in this study is the cardiovascular, metabolic, and functional outcomes. I'm going to go over the hypotheses of our study again to give you some idea of our mindset, the design of the study, the progress to date, and where we hope to go from here. It is a dual-center randomized controlled trial. We asked Shepherd Center in Atlanta to be our contracted site, and they readily agreed. We love working with Shepherd Center. Leslie Van Heel there is a PT, a new PhD, which she says she's going to put on everything, including her Christmas cards. Lovely, lovely, lovely. Keith Tansey, who is an MD PhD, is also at Atlanta at Shepherd Center. Again, a lovely person, both professionally but socially as well. So what we want to know, and this is some of the underlying mechanistic information that as a new graduate, I really didn't understand this. If you look carefully at some of these dates, you'll see perhaps why I didn't understand some of this. This knowledge that we have up here now occurred much after I graduated. So I think many people were asking the same questions as how is this changing the client I'm working with, this movement activity? So I'm not going to go through each of the studies, but as we know, cardiovascular disease after spinal cord injury is a major secondary problem. It is about 30% higher than the general population age and gender matched. And why is that? We're not exactly sure. Somehow with the spinal cord injury is the autonomic nervous system impacted so that there are forces that dysregulate glucose and insulin. Maybe, maybe not. We're kind of looking at that. I think Dr. Becker will address that, I believe, tomorrow in some of his talks. What do we think is happening? Not just with spinal cord injury, but many of our other populations that we work with. So sedentary lifestyle, yes, reduced physical activity, lower resting metabolic rates, they don't burn as much. Glucose intolerance and the metabolic syndrome, a huge problem. One of the things we're looking at with this study is HOMA-IR. Homeostasis model assessment basically is looking at using insulin resistance as an independent predictor of cardiovascular status. The formula I put up there for you, I also put the website because there is a European version. The units get converted a little bit different. We're looking at this because we want to have some idea of what's going on with the balance. So instead of just looking at glucose or just looking at insulin, it's important to have the idea of what the balance is. This is more that mechanistic underlying. As a clinician, I might not have thought of this right off the bat. When we brainstormed it together as a research lab, very important information to look at because as we're finding, we haven't uncoded our data, but just from looking at some of the results as they come back, we're finding some interesting information. And hopefully in a couple years, I'll be able to present this to you with the full data. The fitness component, we're looking at body weight support treadmill training. And Dan was kind enough to send me some of the information he had gathered from a previous report that he did. I've included some of those and updated. Recently, what we have for most of the fitness understanding comes from body weight support. Body weight support, aquatics. How do they relate? Why are we looking at the two? Does anybody have any ideas about that? Why would you compare these two modalities? Aquatics really is nature's body weight support system when you think about it. Aquatics is also a little more available, this is my Paula bias now, a little more available than any of the body weight support systems, whether it's robotic, just overground with a harness system. So we need to think about, are they similar in the outcomes they provide or are they different? So that is at the heart of this research question that we have because really, if they provide different outcomes, then I can't make that statement that aquatics is nature's body weight support. And I need to understand it better before I can truly make that statement with some data attached. There's been a few of the studies, NASH in Miami, big contributor, but again, single episode. Toronto, an open label study, increased whole body lean mass and muscle cross-sectional area in the thigh and the calf. Small subject size. In the UK, again, looking at two subjects, we have some of the peak VO2 data. One subject increased a fair amount, 23.8%, the other 0.5%. That could be marginal error, we don't know. Two participants. Very difficult to make any strong statements, even with the body weight support data that's available. In Turkey, again, we have another study, improved the capacity, decreased the resting heart rate. All outcomes we would anticipate, but have very little data to support. In Italy, 6 weeks, 5 times per week, we saw a little bit of improvement in the cardiovascular status, and that was the focus of their study. I'm in the Baltimore group with Dr. Peter Gorman. He has completed a randomized controlled trial, not with aquatics, but prior to this one, only looking at body weight support. And again, in the treatment group, we saw significant improvement in the VO2 max and no improvement in the control group. But again, small participant size. We don't have a lot of power to make big statements. This is only with body weight support. Then we get to aquatic therapy. Most of you in the room, I'm sure, are interested to be at a World Aquatic Health Conference in aquatic therapy. Who in here is a clinical practitioner? Who actually uses uses aquatic as part of your practice? Okay? Obviously I do, but it's part of what brought me into this whole arena. Frequently used, but little empiric evidence in any populations, but particularly in spinal cord. We have the theoretical principles. We have buoyancy, which everyone in this room is very aware of. We have the hydrostatic pressure. We have viscosity. And the clients are able to move and use the water to get more cardiovascular training because of these hydrodynamic principles. But what are we really doing for that client? Here's the aquatic therapy background. Small print, but again, if you need any of these, let me know. I'll give you my email at the end. A lot of small n's, a lot of case reports, and basically some of the theoretic. We published a paper on looking at the hydrodynamic principles in somatosensation. It makes sense, but do I know that's really what's happening? No, that's a theoretical paper. So we don't have a lot of published data to support with any population. This is not just spinal cord, but specifically for spinal cord, not a lot. So the aims of our study basically were to compare robotically assisted Lokomat training and aquatics, cardiovascular fitness, functional ambulatory ability, and metabolic tolerance. The hypotheses, and this is where my bias comes in fairly strongly. Aquatic therapy will increase cardiovascular fitness measured by VO2 max during exercise 20% or 10% more than the Lokomat training will. Why did we think that? Why would we think aquatics would improve the cardiovascular more than the body weight support system? I'm going to show you a video of what the Lokomat system looks like. The changes of the cardiovascular system by being immersed in general and the fluid of movement. So when you see the Lokomat, if you've never seen someone in a Lokomat, it is guidance force driven. It is robotically driven. The person is supported like in the water, but you don't have the immersion of the water, and you also don't have the fluid. In the Lokomat, you have to be contained a little bit where you don't have to use core stability. In the pool, you're always challenged in your core stability. So I'm assuming, again, a big assumption underlying these hypotheses, that that's going to make the person need to use their whole cardiovascular system more to maintain just their stability. We'll see. We don't have the results yet. We also think aquatic therapy will increase the functional ambulation distance 20% more than the Lokomat training. We're using the 6-minute walk, the 10-meter walk. And we also are using a community step activity monitor, the SAMs. They look like somebody that's on house arrest. Some of our clients get upset because people ask them why they had the ankle bracelet on, especially with White Collar now, where I don't know if anyone watches White Collar, where he has the ankle bracelet on. They look very similar to his ankle bracelet, so people think that they're under house arrest. They're just really under study arrest. And they only wear it for 5 days, pre, at crossover, and at post. But I hadn't really thought about that until they brought up that people have asked them if indeed they are in a witness protection program or something like that. So the methods, without getting into a lot of the details, our participants are a convenient sample of outpatients. We're also listed on clinicaltrials.gov. And interestingly, I have gotten many contacts from around the world. The bad news for those individuals that would like to participate is that we don't have housing. And many are coming from another country that doesn't have any kind of medical coverage even to get them here. Because once they're in the study actually is provided through the Department of Defense funding. But to get them here in the housing is a main problem. The 2 recruitment sites I've already gone over. We are in Baltimore, and Shepherd Center is in Atlanta. The eligibility criteria, 18 to 65 years of age. Level of injury between C2 and T12. We don't want any cauda-equina lesions, because then we're looking at peripheral nerve injury as well as central, and we really didn't want to mix the 2 in the study. Chronic, greater than 12 months since their injury. All their conventional inpatient and outpatient therapy should be completed, or if they've come back for a tune-up, they have to wait 12 weeks till they're finished with that, so we have what we considered an adequate washout period. Age is C or D, and they have to, again, show competency to sign the informed consent and ability to tolerate the standing frame for 30 minutes. Ineligibility. If they're currently performing aquatics in a health and wellness, therapy, anything, or Lokomat, they have to be washed out of that at least 3 months. Uncontrolled seizures, any skin opening greater than 2 centimeters, again, the whole alcohol, and basically any medical condition that makes them unsafe based on the PIs, which is Dr. Gorman and myself, think that they're not going to be safe in either the aquatic environment or in the Lokomat environment. We have repeated measures. Cardiovascular, we are looking at peak exercise VO2 testing during the Lokomat. We're also looking at VO2 testing with arm cycle ergometry for everybody. So the people that are in the arm of the study with the Lokomat get the VO2 testing actually while in the Lokomat. And I think I have a video of that. For the functional outcomes, we have the SCIM 3, the Whiskey 2, which is kind of a gait. The SCIM, I have examples I'll show you. 6-minute walk, time, distance. 10-meter walk. We're using that ankle device to measure step activity, even for individuals who are not ambulatory. And we do have probably about a third of our population in the study are non-ambulatory. Also still wear the SAM, because we're looking at, do they stand more, do they transfer more, is there any change at all? And then we do use a gait right assessment. Is everybody in here familiar with the gait right? Okay, so it has 4 transducers in a mat that you walk across, and it can give you a lot of data about equal weight shifts, step length, stride length. And for those individuals that are ambulatory, we're also doing those as pre, crossover, and post. Metabolic, again, I explained the HOMA IR. And then the qualitative questions and focus group. This is an area that we did not have in the study originally, but we have clients at the end, or even halfway through, or even after 2 sessions. I'm feeling so much better. I can get out of my chair easier. And we hadn't looked at the qualitative piece, which is interesting because part of my dissertation was both quantitative and qualitative. And I let go of that. I shouldn't have. So we have gone back to the IRB and have now included the qualitative questions back in. So only the ambulators get the center part. I did tell you that's partially incorrect because we do have now put the SAM on everybody, just to see if their general mobility changes. The randomization, patients are screened. They have to meet the screening criteria. They basically come in and get randomized. We have a statistician who basically keeps me blinded to which they're going to go into first, into the pool or into the Lokomat. They then get all the baseline measures. We do the Lokomat or aquatics for 12 weeks. We do the whole baseline measures again, and then they cross over to the alternative therapy. So it's a 24-week treatment, but it actually ends up being about 6.5 to 7 months because we have the intervention, plus we have the data collection, then there's always a holiday, then there's the pull down for a few days and all those little details that we'll get to. Anybody see any issues with this design? Has anybody used a crossover design before? This is a clinical design. The washout. Did you hear what Dan said? Dan asked me, what about the washout? So we have them going from Lokomat. Say you get randomized, you come in and you're randomized to start in the Lokomat. You do your 12 weeks in Lokomat. We do the testing. And then that testing is typically done within 3 or 4 days, and you go right into aquatics. How will we know whether the Lokomat provided better improvement or the aquatics, or there was a combo effect? So that is one of the downsides, not just with our study, but with using a crossover study in general. This is another piece of that, quote, knowledge that I wouldn't have had without having the actual study, the actual academic rigor behind it. So what we can do with this is we actually can use statistics to pull out looking at, did the order of entry into the study make a difference on the outcomes? And we'll use a very sophisticated regression formula to look at that. So we're aware of it. But what we need to keep asking, and what you need to keep asking, is are there other issues in the study? Too late for us to change, but if you all start looking in your own practices at some of these outcomes, what are some of the issues?
I had a question
Did everybody hear Chris's question? She asked about what if somebody's out 13 months and somebody's out 21 years? It's a great question. We also will use statistics to go back and actually stratify after. We did not stratify before, only because we only have 36 participants, 18 at each site. To try to stratify with that few, the numbers will still run in any stat package, but what it gives you will be nonsense. So we will go back and later look if we pull out individuals that make kind of arbitrary cuts. They won't be arbitrary. They'll be based on clinical knowledge. But will these individuals look different than those that are newly injured? We have many people in the study that have been out 23, 24 years post-injury and are coming back. We also have some fairly new injured individuals as well.
Paula, going back to your qualitative component, one other question I have, and this is by far not my patient population whatsoever, and I know that there's a varied level of capabilities of your subjects. Is there any kind of spinal cord injury functional outcome measure that could have been used or that you could use in addition to just the qualitative changes in function?
The SCIM is actually a standardized tool. The other one that I didn't mention because I didn't want to put all the details in our screening tool, I actually have everyone fill out a physical activity scale of individuals with disability, which again is another standardized scale. And what it does is it measures time based by patient, by participant report, and activity. And what they have done is they have used a means of analyzing all of that to give different weight for each activity. So that's pre, so then we also will be able to stratify if somebody was very active to start versus the really sedentary person. Keep in mind it's all by self-report. So that's the one downside of using any of these self-surveys. But yes, there is one. And I have a few of the questions from the SCIM I did put in a slide. This is what the Lokomat looks like. And what we have here, I'm sure I must have a pointer. Oops. If you see on his face, he has the mask. We're actually collecting a VO2 in the Lokomat on this individual. The Lokomat is a robotic-driven body weight support treadmill system. It is patented. We have one in our facility. There are several scattered across the country and across the world. Growing, they're getting smaller, so space is not such an issue. And the beauty of this is somebody can be up in the Lokomat and vertical very early, whether it's stroke, whether it's spinal cord injury, whether it's MS, whatever population that you may be working with, you can get them up. Almost no weight bearing, you can unload them totally, or you can then drop the weight bearing as the person's able to tolerate. So there are 3 parameters the Lokomat can be adjusted on. One is that body weight support. The other is guidance force. So I'm going to show you a quick video, I won't run the whole thing, of what the Lokomat looks like. And it actually moves the lower extremities in the gait pattern that is fit to that person's height and weight and length of tibia, fibula, femur, the whole bit. It's all added into the computer so we can get as accurate a gait cycle as possible with a robot. And then the other piece with that is the speed of the treadmill. So you can adjust those 3 parameters and mix them as you need to try to improve the person's function. I don't need to read the slide to you. Basically, we do 2 peak VO2s, we average them, and consecutive 20-second sampling points. I think I have to go here for this.
It looks straight ahead.
Has anybody worked with the Lokomat before? So the screen that you can't see, and he's not using it for the VO2 test, it has a target where we can actually work on if you want more hip flexion, if you want more knee extension. You can actually ask them to try to target, and it gives them a goal. It can show bars. We can show how much exertion they're using. So it gives a different way to train.
How long does it take to get a patient set up?
That's a great question. So the setup for the Lokomat, even when you're pretty proficient, and once you've done all the measurements, you can enter it in the computer and you just pull it all back up, right? But you still have to readjust because we right now have 3 or 4 people in this study in the Lokomat. We have 1 Lokomat. which means readjusting all the straps, belts, and whistles. Really quick, 12 to 15 minutes. Coming out a little faster because you don't have to be quite as precise. It's just undoing. So the whole session for both pool and Lokomat in our study, we tell participants an hour because with the pool they have to change. So a lot of our clients, particularly in the summer, will wear their suits in. Some of them will go home wet because it's easier than schlepping all their things in. Many of them are in power chairs. Our locker rooms are big enough, but not what I would consider utterly adequate to get a power chair in and out, particularly if there's other clients changing. Some will come in dressed for the pool. Coming in for the Lokomat, you have to get it done there. So it does take a little bit more time. How much weight support for him? He was at about 58%. You can go from 0 all the way to full weight support. And that's what we do when we start, again, kind of moderating and modulating how much improvement we see. Oftentimes we have to start somebody with very little weight support, and as they get used to the robot and get used to being weight-bearing again, particularly those individuals who are out 21, 23 years that haven't been ambulatory, they all tolerate it pretty well. But it is a titration, so you really have to be careful how much loading you do and how quickly. Chris?
Paula, does the Lokomat allow for much control or support of the trunk position? And if it doesn't, do you see that as a factor in terms of training core?
Right. So Chris's question was, does the Lokomat allow the individual to pull the core muscles in to strengthen them? No, mainly no, is the answer. It pretty much straps you down. And that was one of the reasons I thought we would actually see more improvement with aquatics, because with the water dynamic, constantly the person has to readjust the core, at least to the level they're able to activate musculature. We'll see if that premise that we worked from holds up or not. This is what an upper body ergometer arm cycle looks like. It's nothing fancy. The model we use we like. We like it because the mask and everything has gotten much more refined. For many of us who did our exercise physiology courses probably a few years ago when we were the actual participants, the mask was horrendous. You had the tube in your mouth. It was horrible, horrible to get on the treadmill and do your VO2 collection. These masks are much more comfortable. The electronic computer system is much more ready to activate, so you don't have to keep the person working quite as hard, quite as long, and you still get the same readings. So basically, that's the set protocol we're using. We used it in the study before. Shepherd is using the exact same study. This is the skim. So basically, this is part of your question asked about the qualitative. This gives functional outcomes, but it lets the person report what they're able to do. We also record it as the therapist. So the person that's involved in the study reports, and we also report what we see. That's on just a couple of the samples of the questions. This is the whiskey, again, looking mainly at ambulations, the whiskey 2. The same thing here, the person reports what they're doing, and we report what we see to see if there's any actual change in the modality they use, the distance they walk. We're trying to look at gait as globally as possible. The other 3 tests I already told you about that we're using, the 6-minute walk test. An interesting component of this, where am I on time? That's perfect. Heart rate, resting respiratory rate, and BP. 3 of our participants, independent of each other, told us that although they didn't feel like they walked a lot farther after each segment, that they felt that they were more fit cardiovascularly. And they said, Paula, you should be measuring our vital signs pre and post with the 6-minute walk test. So I went to the literature, and guess what? It's not in the literature. So from our participants, we're learning. They're absolutely correct. We should be measuring those vital signs pre and post, because the question that Chris asked earlier, somebody that's been out 23, 26 years post-injury, we're probably not going to change their ASIA level that much. However, what we may change is their fitness, cardiovascular fitness level. So to expect them to walk a lot farther than what their musculature would possibly allow may not happen, but they're reporting to me that indeed they were feeling more fit even after one segment of the study. So indeed, I went back to the IRB and tapped in that we are now going to collect the vital signs pre, mid, and post with every 6-minute walk test. It was an aha. Had just not thought about it. This is from 3 individuals, one who has kind of a neuropsych background and is a faculty member, 2 others totally non-health related background, and said to me, all independent of the others, you should be doing this. And they were right. The Lokomat intervention, again, this is our standardized protocol. Everybody gets 3 times a week, pull 3 times a week. Lokomat, again, we cross over. The nice thing with both is their graded coaching is allowed. So we have someone saying kick harder, reach for the target. We do customize both programs, and this gets a little bit tricky in a randomized controlled trial to meet the client's need. So if somebody really needs more hip flexion on the left, then we can train hip flexion on the left. We document it all, but I will show you a grid that we use to try to make sure that the time they spend in each gross motor activity is about the same. The focus of that activity may be a little bit different based on their individual needs. Forgot to tell you also, we use a polar monitoring heart rate system both while they're in the pool and while they're in the Lokomat. It is actually easier for the polar to maintain its contact in the pool than it is in the Lokomat because of those straps, and with the movement, we oftentimes will get movement of the polar device and lose contact. I think I already told you all this. Robotically assisted, so the person is an active assist device. It will provide assistance, but it will let the person provide as much input as possible as far as muscular contraction, partial, almost to 0 weight bearing, all the way to full weight bearing. It is a treadmill training device. We can change the speed of the treadmill, coached exercise, and the visual feedback is that screen that runs straight out toward us that participant number 4 is actually looking at to work on one of the gait parameters that he needed. This is Will Scott. He's the exercise physiologist that's in our lab. Excellent. He really pretty much runs everything about the Lokomat. He runs a lot of things, but his background in exercise physiology, we just couldn't run without him. He is the one that stays on top of the newest changes, the cardiovascular changes, and he is the one that's really his segment of this whole lab. Just some pictures. And your left is Sarah. She's working with one of our participants. Sarah's an OT. She came to me and she said, I would love to work in the study, but it's mainly lower extremity. Can I help? And I said, oh, yeah. So she has been invaluable. She also is an individual, when we get to the end of the talk, who does a lot of the community outreach and has taken clients sailing, has taken them camping in Western Maryland mountains, all part of some of the community outreach programs that we have in our center. Just another picture of one of our clients. What I didn't say is what we've tried to do is match the Lokomat position, vertical position, with the aquatic programming. We felt this was really important because if we're going to compare Lokomat to aquatics, it really should be as close to apples as we can get and not apples to oranges. So while they're in the study, clients don't do any swimming per se. However, I'll tell you a little bit about one of the perks is that they then can join our wellness program gratis. That's one of their feedbacks. Whether they like the Lokomat, like the pool, we can offer them the pool program as a wellness participant. And many of them do come back, and we do work on swimming adaptations and anything else they might want or need. We have 2 participants in this video before I turn it on. This individual is fairly involved. He was actually served 2 tours in Afghanistan, safely returned home, came back, went to a bar one night, decided not to drive because he had been drinking, walked home, someone hit him, creating, it's the saddest story I've ever heard, well, one of them, TBI and spinal cord in that injury. Very, very involved individual, loves the study, has done very well. This individual, again, manual chair, power chair. You'll see again what they can do in the water, which again, I'm not telling anybody in this room things you don't know, but it's a very powerful statement when you see what they can do in the pool versus what they're available as far as movement and cardiovascular. Crossing across is P13.
Take your time, Ms.
They get a
Reagan.
big joke out of this. They'll send me a note, AKA P13, because they know we're not allowed to use their name, so they really kind of think it's kind of neat. So they'll talk to each other, P9, calling P9. B13 is totally in a power chair, non-ambulatory on land. His gait, right there, what do you think about his gait? It's not overly pretty, right? However, he can walk without floats. He's actually using the floats to get a little upper extremity resistance to get the core. So when we started
okay?
with anything or with paddles.
All right.
What we've gone to with him, because we
Okay.
didn't like
Hold
that pelvis position, we've gone to a long bar when we really want to work just on alignment. And then we do about 4 or 5 laps of him trying to drive through with the floats to try to get him to pull in the core. Because I wasn't happy with that alignment in that position. He was all over the board with his alignment. So again, we get to customize what we need, but we still need to get the cardiovascular high enough, which is the other reason we're using the Polar device that gives us readouts. It gives us an indication of where we're pushing as far as cardiovascular limits. And I don't know if you remember when I went through the protocol, we work between 60 and 75% of their cardiovascular possibility.
Paula, the individual with the TBI that didn't exclude him from the study given all the motor control issues with the brain injury?
Yeah. No, we didn't exclude him. It's not in there. He actually has a lot of trouble with short-term memory. However, he's an electronic wizard. So when I can't get the Polar device to work, the other client will just take it from my hand and hand it to James and say, fix this for her. He hands me his iPhone and says, put all the dates in for me. Or I email him dates or any changes. So electronically, his processing is still good. Short-term memory, auditory, not so good. Able to follow directions, though, able to participate fully. So it's interesting, even with the TBI, we felt he was more than appropriate for the study, but good, great question. This individual is probably one of the individuals that should be most inspiring for spinal cord injury. One, he's a great guy, totally in a chair. He's a very high AGC. We really weren't sure, we being mainly me, that we'd be able to get any reciprocal gait with him. He really has trace function as some of the key muscles for gait. He has gone on to, by the time, this was early on, and you see some very limited hand function. By the time we finished, he basically was walking with me. He called me his human walker. I would walk in front. He would put his triceps on my shoulders because he's about 6'4". I was the perfect human walker for him. And I wouldn't even need to facilitate the pelvis by then. We trained some of his family members to come in and actually continue once he discharged from the study and he comes in for wellness. He had no possibility of any way to get the cardiovascular stress that he is getting in the pool. So again, you know where my bias is. That's why I'm at this conference. That's why I'm involved in the aquatic section. But it's amazing. Everything else we've tried with him, upper body ergometry, just didn't give him enough. And here, he says to me, he's a very bright, articulate individual. I know I'm never going to walk again on land, Paula. He is about 23 years out, was injured playing football at the age of 18. He knows he's not going to walk on land again, but he said, I'm coming here as often as I can because it feels so good to be upright and moving on my own. So it goes back to that quality of life, qualitative outcomes.
That was my one question for you, because I'm a qualitative person too, so I love that stuff. Did you think about putting the quality of life indicator in as one of your outcome measures just to tease out more than if you didn't get the answers you wanted from the question?
So the question was, did we think about putting the qualitative piece in? And originally, we debated it and thought we had way too many outcomes, so I let it go. Again, I told you my bias. My dissertation contained both qualitative and quantitative components. I let it go. And then when we started getting reports like this, I went back and said we need to add it in. So we did go back to IRB and have now included 3 very short qualitative questions asking about what changes they perceive, what they feel. Because we're measuring what they're doing, but what we weren't getting from all of our outcome measures is what the patient or the participant's perception actually is of what they're feeling, what they're perceiving. And again, this individual, wonderful, articulate, designs the software programs and the databases for Social Security. So, you know, he really is engaged in the workforce, but he makes time from his day. And meeting days, he couldn't come. He would actually come dressed in a suit. And he said, I can't show up at meeting days in my trunks. And other days he could, because he could go into the office with just a long-sleeve shirt and his trunks on. No one would care. But meeting days, he would always come in suited up. So we get a big joke about meeting day for him. The aquatic therapy protocol, and this gets tricky for all of us in the room, right? We need to standardize, because it's a randomized controlled trial. From participant to participant, we need to be fairly rigorous, and from site to site, we need to be fairly rigorous. Water depth, again, work at the level providing the highest level of function while challenging that core stability and balance. So you saw P13, that gait didn't look so pretty, but we were, at that point, that part of the video was challenging his cardiovascular system. Told you we switched to a long bar to give him more stability to actually work on pelvic, underneath, shoulders, getting the alignment. Position in the water, upright, horizontal, semi-recline. For most participants, I've already told you, we really try to match the vertical position of a Lokomat. With James, one of the participants, I do put him horizontally occasionally because he has a lot of tone because of his injury, and I may spend a few minutes in Ba Raga or Watsuing him and then get him back vertically. It's all documented, so we'll have some evidence of what we did. For the most part, we don't do a lot of horizontal work, again, trying to match the Lokomat. The water depth, again, challenge as much as possible, but still trying to keep neutral alignment, all the things we want to do. And the activities, we're really pushing gait training, because again, the Lokomat's pretty much gait training, and cardiovascular. Strengthening, you get some strengthening in the Lokomat, but I think we're probably able to facilitate more strengthening in the pool because, again, of the three-dimensional component of the water. That's Paula's thinking, though. We have no proof yet.
What's the temperature of the water?
Temperature has to be below 90 degrees. We haven't bottom limited it. My preference is 87 to 90 is what I prefer, particularly if I'm in there with the individuals a lot. I try not to be the primary provider since I am the PI. Occasionally, I am the backup. And you did see me in the pool with one of our participants. So the individuals that need hands-on and a little higher level of skill, sometimes we often don't have enough other therapists that are certified to be in the study. They're off, so I'm it. The water temperature in our pool is just about 90 degrees as much as I can keep it there, because all the wellness individuals would prefer to have it at 95. And Shepherd really struggles to keep theirs at 90, 91 as well for the same reason. They have a very healthy wellness program there, and the individuals prefer the water be warmer. 40 to 45 minutes both in the Lokomat and in the pool, with our promise that we try to get everybody out the door in an hour, whether they're in the pool or in the Lokomat. And of course includes changing time for both modalities. Minimum of 60% their maximum age, basically, and then the cardiovascular component, 65 to 70%, and aquatic adjusted heart rate. And I don't know if you've all seen Don Gulick's work. This was in the book that Lori Tyne and I did. And Don went back and actually kind of went through some of the height of the water depth and adjusted that way. We used Don's formulas because they're fairly straightforward, and she pulled it pretty much out of the literature and summarized what was in the literature. So again, this should be in the slides that you have if you want to use it. I'm quite sure she'd be thrilled with it. I'm going to go back and make sure. This is our protocol. When I presented this to the group, they were not happy with me, right? Because this is kind of nebulous. But if we have individuals with different needs coming in, and I'm going to ask them to spend 7 months, 6.5 months to 7 months of their time, I need to guarantee that I'm going to be working on what they need, right? So I broke it down. Basically, we do a warm-up, we do a cool-down. We have a lower extremity muscle strengthening component, a cardio component, and then sometimes the cardio component is kind of cardio plus, which will include more dynamic stability exercises, and we'll pull in core strengthening. We don't do any upper body per se, although you saw people with resistance, only because the Lokomat does not include upper body resistance, and Chris alluded to that earlier. So the therapists go through, and these are just ideas I put in for them. They can change what they use. They can change positioning. They may drop out of cardio and put in core in the line, but they get recorded both electronically and still hard copy in a binder, so we know exactly what was done with each person. In case we find an anomaly that this person did really well or not so well, maybe it was what we did in our protocol design. I'm going to ask all of you as practitioners to help me think about another way that we could better standardize this. This is what I came up with after a lot of deliberation, trying to be able to customize enough to give each participant what they need, but be able to standardize it enough that across site and across participant we're being consistent. You all know this, basically using the hydrodynamic principles of the water. These are the things we're really working for. We use the deep water a ton, even for individuals that are not swimmers. That can really get the heart rate up for these individuals with spinal cord injury. So we didn't realize how big the deep water was going to be. Huge component. I've already talked a little bit about the polar device. The rate of perceived exertion, we use the Borg 6 to 20. Again, another client tidbit. They said sometimes it's hard to do the exercise. So when you're asking me how hard, what was the hardest thing I did today and at what level, do you mean how hard was my heart working or how hard was my body working? And I went, huh. So back to the literature I go, and guess what? It's cardiovascular in the literature. So we have now started recording both a task difficulty level, which may or may not be the same as the cardiovascular most difficult activity. And we asked for a number on both. And again, that was participant driven because some of them said, well, that's very easy for me to do, but it gets my heart rate up. That was very hard for me to do, but I couldn't get my heart rate up because it was so hard I couldn't drive my heart that much. So it's interesting, most of these individuals that gave that feedback, no healthcare background at all. Blood pressure, this is one other little trick that we did get. I love it. Hadn't thought of using it. Monitoring it right. It's one of my big soapboxes when I teach, when I practice. Need vital signs, need the vital signs. I got one of those little wrist cuffs. Can't leave it on in the pool, but it sure is a lot easier to check vital signs at poolside than trying to get a cuff and everything down there. Gives you heart rate and blood pressure. It's perfect. It's held up now for about a year. I didn't use it right from the beginning, and it was also hard to hear in the pool to get the blood pressure and the heart rate because of the acoustics. Therapists love me because of this. It cost $38 online. So it was a very inexpensive fix to us not being able to get adequate vital signs because of the acoustics in the pool. Not so bad in the Lokomat. It's in our gym, but not quite as noisy there as the pool. So where are we? Right now we have screened 29 people. We've randomized 25. 4 of those 25 have dropped out. 1 actually got us a published paper in Journal of Spinal Cord Medicine. We had an autonomic dysreflexia incident. This is somebody that was after 26 years. No incidents at all in the pool. In the Lokomat and his 8th session, spiked the blood pressure. We checked cath, we checked everything, we tried him again, spiked again. Checked again, checked his renal function, spiked again. We had to discharge him. He's perfectly fine. This is an individual that, again, very knowledgeable of his spinal cord injury, knows what AD feels like. He did not have any true symptoms the first time. The only reason we picked it up was that he said he was feeling he was working hard, which he was. We did our regular blood pressure check, which we do in the Lokomat as well as the pool, pre, mid, and post, and it was sky high. But the normal symptoms he would feel, he was not feeling. So, non-study ankle fracture. We have somebody that's a pretty zealous participant, love the pool, and almost at the end of the pool session, fractured an ankle unrelated to anything in the study. We had a strange non-dermatonal pain reported being in the Lokomat. My gut feels he just didn't really want to be in the Lokomat because none of the pain report made any sense at all. We had to discharge him from the study. And we had a non-study related skin integrity issue. So those are the 4 that we've had to drop out, all unfortunately at our Baltimore site. Lessons learned. Compliance to training schedule. We have 2 rehab nurses that work in our lab. They're very good at trying to keep people motivated and staying involved. As a team, I think we're pretty motivated to keep people involved. They like us. They like coming to us. People are interested in them, and they're getting 7 months of activity that many of them haven't had for quite a while. The practical issues, like the pool closures with lightning, if it's when we have a training session, many of the people can't stay for later because now the schedule's ruined. So all these little practical, clinical pieces come into play. The Lokomat training, this whole risk of atypical AD, and then the skin abrasion issues. Leslie at Shepherd has found this nice padding that we usually use more with seating systems. I call it chicken fat. It looks like chicken fat. You can get it fairly thin, and it can come in pieces you can actually cut to custom fit. We started using that at about month 3 after Leslie and I talked, because in the prior study they had a fair amount of abrasions. Once we've started using this chicken fat, padding up everything inside the straps of a Lokomat, we've had much, much decrease in any kind of abrasion. Pool training, the need for customization makes it difficult because, again, we have to be consistent. The equipment and water safety considerations, and that each person is assessed for their own safety, basically, typically the second session. Because I don't know these individuals usually. I have not been the one that's ever treated them. I usually do breath control. I get in with them and I do the screening. They have to show me that they have breath control with face in the water. If they refuse, that's a no for me. If they try and can't, obviously a no. They have to show me they can float prone and or supine, or at least try. And they have to change from prone to supine. I also want to see them change position from a float to get the feet down. I'm not so worried about them getting to a float because not such a big deal. And if they are or wanting to swim later, I want to see them try to swim with or without flotation devices. Even though I said we don't do a lot of swimming in the study, we are with them all the time in the study. However, when we get somebody that's really functioning pretty high with the cuffs on the legs for resistance and the arms going, we did have one gentleman tip over. And luckily I knew he really did not have the trunk strength to even roll. I was in 2 seconds, as was the lifeguard, and as was a patient that I had been treating who was actually closer to him, and Wally got to him first. All we had to do was flip him. But again, we're dealing with individuals with spinal cord injury, so they may not have the trunk control to flip, even though they're actually going pretty well with the arms and the legs. Chris?
So, Paul, you assess whether they can change from prone to supine, but you don't require that they can accomplish that?
Right. What I do with this assessment is I basically, are we done? Let me just flip through this. What I do with the assessment, because we have a few minutes for questions, right? Since we included questions. What we do with that is it lets me know as the therapist and whoever else might be working with them, and I also let the lifeguard, who's always on the deck, know that this is somebody that has no breath control. That means absolutely no questions asked, get in the water and get to them. So they get flagged as not just a swimmer, non-swimmer, because most of our clients are not swimmers. They get flagged with breath control, no breath control. These are some additional study benefits. Increased attendance at the spinal cord support group. We didn't anticipate that. Basically, enrollment in other studies, you would think that might happen, but not always the activity studies. We have an auricular acupuncture study that's enrolling right now, and many of our clients that we see have neuropathic pain. So this is a neuropathic pain study. The video that we did for the APTA, one of the main participants was a participant in the study, and he was just thrilled to participate in that video. Another client, now that we're interested in her, is coming back. We helped her look for sites that she can continue and finish her bachelor's degree. She's going to look at rec therapy. We did publish the article. Several of the participants are now volunteering at the facility. And what I have next is a picture of some of the sailing and jet skiing. This is the individual who actually ended up with the TBI and the spinal cord injury, very limited in what he can do in mobility on land. He is sailing on the bay. So it's huge for him because he got involved. So this has become more of a center concept and not just the research project in itself. To see that look on his face with him sailing on the bay, that was not an outcome of our study that we ever anticipated. But to me, this is better than any output he's going to give me from his cardiovascular status because he's engaged in this group and he's going to go. I'm almost there. Future undertakings, I want to look at metabolic a lot more. For most of us as we age, not just individuals with spinal cords, that central adiposity in the abdominal area that offsets a lot of our resting metabolic rate, our adiponectin, our glucose and insulin intolerance. We actually want to do a regional conference. The quality of life we're going to hit a lot harder. So not just a few questions, we're actually going to do more of that. We're going to do another proposal is in right now for looking at community education regarding aquatic exercise. For individuals with spinal cord, we won't do the exercise. We will educate community pools, therapy practices that may not have thought about using their pools for active exercise for individuals with spinal cord injury. And then I want to look at bone density a lot more. We have hooked up with a nice new imager who's moved to us from Texas, and he's very interested. My last slide, basically just acknowledging the Department of Defense $1.5 million award. This is huge. This was lucky lotto, though, I'll be honest. This was a great grant that we put together, but getting that kind of money in this climate is very difficult. So I am thrilled as a therapist that I'm able to investigate what I really do. I mean, I have an opportunity here that I feel like I need to do a really good job because this money doesn't come very easily. And then again, of course, everybody, these are the therapists, the support staff, our research nurses. We can't get it done without them. It's a really nice group. And that's it.
Thank you, Paula.
I'm currently involved in the design of a hydrotherapy pool. I'm very interested in your comment about the acoustics. What do you recommend?
I'm going to defer some other people. I just know we have an older pool that has very high ceilings. It's got gorgeous open windows, which was the whole design. But that high ceiling, open, kind of cavernous area, it's very difficult to get any kind of vital signs. So I'm going to defer to somebody in the room that knows more about pool design. I would just not suggest having these huge open spaces. We've actually tried some material like dampening. It's helped a little.
You're looking for less reverberation or what?
Less noise echoing. Yeah, it's very difficult to give instructions, but also then even monitoring vital signs is very difficult with that much of a noise. Go ahead.
I am working at a pool that has a very high ceiling, but when they built it, I don't know if it was acoustic tiling that they put up there or what, because there isn't that huge bounce of sound. And I work with children who are very sensitive to noise, so it's actually been a really nice thing for us.
That is nice.
So I think there are things that can be done. I don't know if they have to be done from construction.
And there are several people here giving talks. I met two of them at breakfast on design. So it might be good to see when those talks are because they may be able to give you specific ideas on acoustics. I just know if we had to redesign ours, I would definitely, that would be one thing I would change.
Very nice piece of work, and I think it's going to be very exciting to see what happens. One of the other reasons why you may wind up with an enhancement in cardiorespiratory fitness as a consequence of the aquatic group is the respiratory workload that they're experiencing when they're especially in deep water environment. And at some point in the future, as we've spoken, I think it would be wonderful to see if we can add that to one of the major pieces.
Yep, that's great. Dr. Becker just added as far as the load onto the expiratory system, basically, while they're in the water, the pulmonary system. There was another question or thought in the back? No, you can't wear it in. However, Sarah dropped it in and came running to me one day. Oh, I dropped it in. I said, we have rice? She said, yes, in the rice table. I said, get me rice, stat. So she runs off to get the rice. I take it all apart, and we drop it in the rice. We let it sit overnight, and it worked. So it's not waterproof. And, everybody's like, oh, we knew Sarah would be the first one to drop it in. And sure enough, she was, whoever put money down on Sarah. But it's still working. And for $38, I'm pretty happy.
All right, thank you.
Thank you.